Hey everyone, welcome to another episode of KLF Deep Dive. I'm here with Deborah Williams. Deborah is so fascinating because she's bringing this wealth of knowledge. I'm really excited, but I'm going to let Deborah introduce herself and then we'll go from there. So Deborah, tell us a little bit about yourself.
Okay. I'm a policy researcher and I've worked in healthcare policy now for actually over 3 decades. And as Susan Densler said recently, it is the triumph of hope over experience. Well, because problems are never solved. And one of the things you suggested for us to talk about today, hospital outpatient payment, drug payment, and how a bill becomes a law, is something that has been a long time, like a 3-decade old argument. It's sort of ironic in a way because the problem's been solved in other dimensions, but not in this particular dimension. And we can talk about why. And I think that's an interesting discussion to have today.
What I really like about what you're talking about is this is a battle that's been ongoing for 3 decades, basically. Talk to me about what started these battles in the first place. When you got involved, why did you get involved? Why was this a topic that people were arguing over at that point?
First of all, when a payment system comes in, you have no data and you have very incomplete information. So let's talk about first about the incomplete information in the 340B program. Congress heard complaints from hospitals and from entities that once they passed the Medicaid rebate, because it had the best price component, that they were no longer getting the best discounts as volume-based purchasers in the case of very large safety net hospitals. Thomas Jefferson, where you are or were employed, is a perfect example. Cook County, LA County, all perfect examples. The problem was they went too fast, in my opinion, if you're going to ask me. And this is typically, especially certain types of legislators tend to legislate on the fly what they believe. They believe it seemed reasonable that under a best price scenario, that at that time, the normal rebate was 13%, I think, so that these entities were not getting the best price anymore.
So why did these rebates exist in the first place? You said so it was just you have to give the best price. The best price is whatever you charge minus 13%. Is that where it started from?
Well, it started from the Medicaid program, which is they wanted the Finance Committee of the Senate wanted to give reduce the costs in the Medicaid program. So they implemented a rebate.
Okay.
And it started off at 30%. And there's a best, and it went back and forth in legislation over a couple of years about what it had and what it didn't have. And it has an inflation component and it has a 13, but it also has a best price. So Medicaid at the time got the average manufacturer's price minus 13% or best price. That means that or as they always say, the Democrats who wrote the legislation, the program for the poor gets the best price. But immediately it started having problems. And I would have to say that over 30 years, it's had nothing but a series of litigation, problems, fixes, more fixes, it didn't work, flood fixes. People seem to be tired of fixing it. We won't even get into that. But immediately, the first problem that arose after the Medicaid rebate is that the safety net institutions, hospitals and the Ryan White centers and others said, we're no longer getting the best price from manufacturers. And maybe they were, or maybe they weren't, but there was no data on it at the time. But they had a hearing and they had a GAO report which said, we don't really know anything. So that's what they had, but they went ahead and passed the legislation anyway. And we're going to get to the kind of the crux of our story, which is when Congress passes legislation, there's usually only the Medicaid rebate is in finance. So they passed it. And so HELP and the Energy and Commerce Committee, they did 340B. So the two aren't connected. I've been told by Kennedy's people, told me the time when I was researching it in 2007, look, we're a little jealous, Medicaid gets the best price. We thought our grantees should get the best price too, because Senator Kennedy was very passionate about the grantees. So Energy and Commerce has jurisdiction over Medicaid, right? But they
Okay.
also do over the Public Health Service Act, which is where 340B sits. Finance has jurisdiction over Medicaid and Medicare. And HELP has jurisdiction over the FDA and the Public Health Service Act. So you often run into like little problems and major jealousies when you get more than when the big dogs all start to bark. Let's just put it that way.
Walk me through how this bill, I guess, it goes through each of these and what each one's saying. Like what each one sort of probably wants to put their hands in there, but is this one of those things where everyone gets to have a voice? Or is this more of a I only handle my portion of it and then pass it on to the next one? Like how does this get managed?
Well, every the committees and Congress change over time. One of the things that remain the same is that revenue generating bills have to start in the House.
Okay.
So you have, and Professor Nick Pay has written an excellent study recently on the back and forth on the history of 340B. So at the time, Henry Waxman was the chairman of the Energy and Commerce subcommittee that was relevant, and he was very powerful, time and about getting legislation. I don't happen to care for him personally, but he was very successful at doing any number of things. And he, of course, was very passionate about Ryan White.
Okay.
So, and at the same time, there were a lot of people, for example, I won't even get into the veterans part about it because it's actually tucked into a bill called the Veterans Health Act.
Okay.
But we'll just skip that part.
Leave that for now.
At the same time, you have the Senate, for example, if a bill has to pass, there usually is a matching bill in the Senate. They go through parallel, and it may be that there's a lot of variations in this, okay? The Senate could pass the House bill without any changes. Very rare, does happen. I worked in the House for 6 years on the Ways and Means Committee, which doesn't have jurisdiction on Medicaid or 340B, which itself, as our story unravels a bit, poses its own problems. Eventually, the 340B came in and it was put into the HRSA, but HRSA was given very little legislative authority to implement. At the time when there was a tendency to write legislation, if you look at the original legislation they were writing around that time, around 1991, 1992, 1990, it was I wrote more lines in 2003 on the hospital outpatient section than you will find in most of these bills. And although you don't want to know much about the DRGs, for example, that would be a good example of something that was put into law, which was very vague. So a lot of people you see, if we can jump ahead for just a second, who complained about the 340B program today, it's because its style represents a style of legislation and law that's no longer used very much. It's not, shall we say, current.
I didn't even know that laws have styles.
Right.
What does that even mean? When you say a law has a style, what does that mean?
A style is, I'm going to trust you. I'll give you some general guidelines, but I'm not going to do anything more. As opposed to, for example, because I came out of I came out of sort of the oversight commissions for Medicare. And I also had then worked 6 years as a lobbyist for the American Hospital Association. And frankly, I didn't have much trust for the administration. So if you look at the section that I wrote, which was one of many sections of the hundreds of pages of bills that I wrote, you'll see that it's very detailed. In fact, the Supreme Court said about that section, they said that they admired how immaculate it was. I only see the flaws in it. But it's very detailed, extremely detailed. So that's a style. So if you look at the 340B program and you hear what people have to say about it today, that it's too vague, it doesn't have a lot of clear, bright lines. And in fact, it hardly has any.
Okay.
Find related podcasts below.
Um, what you're saying is that stylistically, that's what the Democrats used to do. While I assume the converse is that the Republicans would write more detailed laws. And if that's true, is there less interpretation by the executive branch for that style of laws, if you will?
Yes, obviously, because and it's meant to have less interpretation. But now, if we look at the courts have changed, and this gets us to be, if when we talk about the hospital outpatient provision, to be very important because Chevron is no longer the standing policy. And really, in some ways, it was. If you read, for example, the Congressional Research Service has said, as a standing policy, it had a lot of um, some circuits, some circuits always applied Chevron, some did not, some did it in a
Right.
mixed way. The Supreme Court, it's not always very consistent, but generally the Chevron decision sort of like in some ways codified, I guess in a way, codified is not the right word legally, but the administration's ability, but that no longer stands. And so
Right.
this becomes very, very important when we get to a very specific part of the law, like the hospital outpatient
Got it.
law. It all fits together, you see.
Hell, I'm like swimming in data already, but please continue.
Well, so I talked about the fact that there are these committees sitting over here, Energy and Commerce and a Health Committee, and they worked to pass together because they thought they were responding to a constituent problem, and they wanted to nip it in the bud. Sometimes Congress nips things too quickly. Sometimes they wait until it's a crisis.
Right.
So there's very few, in my observation, there's very few happy mediums. So they passed this law that now, because it's so vague and it itself is inconsistent internally, has caused a lot of problems. And HRSA has not been exactly the best steward, in my personal opinion. They made a lot of interpretations of law, for example, like contract pharmacy. At the time, the manufacturers, and I can tell you this for a fact because I worked with the manufacturers for a manufacturer at the time when they did the contract pharmacy law. Um, they didn't want to sue their customers, and they didn't want to, they didn't want to sue the agency. That was a mistake, but it's neither here nor there. Except they didn't really have authority. But at this time, there's some general argument that because they didn't object at the time, blah 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 blah. Okay, so you notice that when we look at it today, that the committee chair, the chairman of HELP, the HELP committee, which has a jurisdiction under the Public Health Service Act and 340B, he wants to change 340B and set a limit on the number of contract pharmacies, et cetera, which would, seem might be reasonable. There's no reference in the law to contract pharmacies. There's no reference in the law to pharmacies. There's
Okay.
just entities. So this is another, you would have never gotten away with something like this on the hospital side. Anyway, that's neither here nor there. Very 340B. So here you have a very general law, sits over in two committees, Energy and Commerce and HELP, but relies a lot on definitions that are passed in other parts of the healthcare, Medicare, and Medicaid. And this itself causes problems because over time, the hospitals sue, they get changes to the law, the Medicare disproportionate share definition expands and expands and expands. That means the number of covered entities expand and expand and expand, putting pressure on the whole system till, 40, 50, 60% of the, for example, the medical benefit drugs are sitting in 340B. So it
Right.
creates an intolerable pressure. At the same time, there are other pieces of law that also create intolerable pressure. Like, for example, let's face it, manufacturers were able to raise their prices and price out of the pressure.
Right.
So, they were even so silly that they even gave bonuses relatively speaking, to people who were selling into all these sites. So, but what happened in the Inflation Reduction Act is now there is, if you raise your prices, you're going to pay a Medicare rebate based upon that utilization.
Right. Right.
So now we have a crisis. All
Okay.
all done by laws that were all separately arrived at by different committees. So you've got over here, you've got finance passing the inflation rebate, the House agreeing with that, and then it's putting all this pressure on the 340B program.
Right. How are you involved, or to the extent you're tracking it? What is this? What is the solution now? Where for the 340B program?
Well, I mean, I think that people are fairly realistic that they're not going to, I hope they're realistic. Hospitals are one of the most powerful advocacy groups in the Congress.
I don't know.
And yeah, that they're the majority employer in many states. It's either, honest to gosh, it's either Walmart or
Yeah.
it's some of these big hospital systems. Think about where you sit in Philadelphia.
Yeah.
So you think when Thomas Jefferson and some of the other hospitals bark,
And yeah.
do you think their members listen? I think so. I think so.
Yeah.
And that plays out all across the country, especially, think about the House. We talked about the People's House. There's a lot of rural districts where a big hospital might be their premier employer. So even though, for example, there are many undeserving hospitals, not so much the small rurals or the Thomas Jeffersons of the world, but the Stanfords and the Mounts, and what's the hospital in Beverly Hills? Is that Cedars? Cedars Henry
Okay.
Waxman's hospital was in his district. Um, so there's undeserving hospitals. I don't know how many poor people they get. They had to have a special lower bar created just for them, and they had to buy up some outlying hospitals that had a lot of poor people in order to be eligible. I guess that they have maids that probably break their arm at work and then have to get treated there. I don't know, whatever. They don't treat many poor people, period.
Yeah.
Um, so I'm digressing a little bit. A lot of the reforms that really need to have happen that really focus it down, because we still have, despite the 20 or 30 years of this program, we still have a huge affordability problem in America with drugs. And
Absolutely.
study after study and survey after survey show it to be the case. And although, for example, the federally qualified health centers are required to have a sliding scale, hospitals aren't required to have a sliding scale, except for people without insurance who are poor. It's one of those notch people. That is, he was no longer working because he had cancer. He was 62, but not eligible for Medicare, right? And he wasn't poor. So he didn't have any insurance at the time. And so Duke charged him $1,000 for an oral cancer drug, which I happen to know because I work for the company, cost a penny. Cost them a
Wow.
penny. And this
Wow.
is not uncommon. And if we were going to talk about, so let's go back and talk about the process of legislation. So over 30 years, the fact that we've had all these different hands in the pot, all these different objectives, none of the problems are coordinated. The programs are trying to achieve their own best ends, right?
Yeah.
Trying to do the best by which they could, but in combination with those things, they often can create a toxic system or a series of levers and pressures.
What was the root mistake we've made, and how do we fix it if we could do this all over again? Because it sounds like part of our problem is just we keep fixing and patching.
Well, when a problem has gone on this long, it's very hard to patch it,
Right.
to fix it because there's too many economic interests involved. But if I was going to wave my magic wand, I'd
Yeah.
say we have an affordability problem for people. Let's address that. And if we have a funding problem for safety net hospitals, let's address that. And let's address those things directly and
Hmm.
clearly,
Okay.
in a well-defined way. as opposed to these roundabout ways with their terrible incentives. And if we have a funding problem, which have been demonstrated over and over again, to use more drugs and have created this huge incentive, as you know, for hospitals all across the country to hire oncologists, et cetera, et cetera, et cetera. And all this has been demonstrated in paper after paper after paper, which will probably never be demonstrated, all because the merits of what they were doing weren't clear, that if what they were trying to do was give funding to, they were trying to, for example, pass something that didn't have any costs, quote unquote, not real costs, scored costs. Well, scored costs means that it's a change to Medicare or Medicaid programs that affects costs, or it's a tax system. The fact that in 340B, you have $1 taken away from taxable entities and given to non-taxable entities isn't scored. Now, that doesn't mean that it has no cost, the tax system. It just means it's not scorable under the Budget Act, which was passed during the Reagan era. So, I really get irritated when 340B entities say it has no cost. No, it has no scored costs, but it has plenty of costs because you're taking away taxable revenue and you're giving it to non-taxed entities.
Follow our page on LinkedIn.
Interesting. Wow. Deborah, how can people talk to you to get more details to understand this a little bit better?
Well, they can always contact me through LinkedIn. As you know, I'm fairly responsive to my messages, and I will talk with people.
I love it. Please contact Deborah if you are a 340B system that wants to talk about how your processes work. And if you want to reach her, find her on LinkedIn. Deborah, this was amazing. Thank you so much. What I learned is I know nothing. I am very much like Jon Snow right now. So thank you for the education. And that was incredible. Any last words?
Well, mistakes were made. That's all I can tell you.
Perfect. Deborah, thank you again. Talk to you soon.
Okay, bye.
Call, click, or email